Hi, this is Dr. Karrie Hohn from Palm Health, and today we're going to talk about perimenopause and menopause. So give me a minute just to grab my slides and we will get started. Today we're going to talk about hormones, crazy hormones. But I want you to know, above all, if you remember anything from today, you are not crazy, it's your hormones. So I want you to think about as you move forward through menopause, or if you're looking back at menopause, think about what you've been through. I can distinctly remember a day when I was 46 in mid-March of 2017, and suddenly I felt like something wasn't right. I was more stressed, more anxious. I wasn't sleeping well. I was having hot flashes and night sweats. And I remember that I would feel great for a while and then I wouldn't feel so good. And then I would feel great for a while and then I would not feel so good. At that time, I began to have dry mouth, dry eyes. I had cavities for the first time in my life. I had aches and pains and just was irritable. And I knew my cycles were changing, but I really didn't think this could have been any sign of menopause because I was still having a menstrual cycle. So for me, I'm now 53. That was 46, 47, 48, 49, 50, 51, 52, 53. That was that long ago, 7 to 8 years ago, where I began to have those symptoms. And really now just putting this talk together, put that together and understand how impactful menopause can be. And we'll unravel those symptoms that I've described and help everyone kind of look at symptoms that they might be having in a different light. So just to give you a summary, menopause and perimenopause are associated with significant and long-lasting effects on health and well-being. Many primary care and gynecology providers are just not equipped to help women best manage those phases of life. I can tell you just 8 years ago, I wasn't equipped to understand it fully. And I'm just coming in this last year into such a greater understanding of the full impact of menopause. And there are quite a few providers who are this interested as well, but not everybody has the time or the bandwidth to dedicate to this part. They're busy delivering babies, doing surgeries, seeing people for well woman exams. So just keep in mind, it's important to suss out and find a best provider who understands the depths of menopause. And I want to give you some tips and pointers on what to look for and what to ask for. We do know as well that life habits such as sleep, exercise, diet, stress reduction can greatly impact perimenopausal and menopausal symptoms. Menopause and hormone replacement can be safe and effective for the management of perimenopause and menopausal issues. So there was a study that was done back in the late 1990s. At that time, I was a resident at Mercy Hospital in Creve Coeur, and we were seeing patients, and we told our patients, you know what, there's a risk of cardiovascular disease with menopause, heart disease, and stroke, and we feel like there is a benefit based on studies that were done in the decades prior, telling us that hormone replacement was a really good idea. And so we had many of our patients taking Premarin and Prempro. Those were the menopausal drugs of choice at the time. There was a study that started to further assess the risks and benefits of hormonal menopause replacement, medication hormone replacement in women to see if there really was a benefit and if there was a risk for cancers or how that weighed out. And what they found was in that study, they had different groups of women. They had women who had a uterus still. They hadn't had a hysterectomy. Those women were taking Prempro, Premarin, and Provera, which is estrogen plus a progestin, and they had women who didn't have a uterus. They were just taking Premarin. That was only the estrogen. And so 16,000 people and women in this study, 10,000 in this study. And what happened was they stopped this study early July of 2002. They had a large press conference, and this is when I was a newly practicing physician, and they said that menopausal hormone replacement was associated with breast cancer, stroke, heart disease, blood clots, and overall cardiovascular disease. So we who were practicing medicine said, oh my goodness, we have to get our patients off of these meds. So we either tapered them off quickly or we stopped them immediately. And a lot of women suffered severe symptomatology. So their hot flashes came back, their night sweats, their mood changes, all of these things, because everyone at this point was afraid of the hormone replacement, thought it was dangerous. What is interesting and what did not make the press was that that part of the study was stopped. The other part of the study, which was estrogen only, was not stopped. And it went on until March of 2004. And that study showed actually beneficial trends for breast cancer and heart disease risk. So it was just impressive that the negative data got so much more press than the positive data. So over the past 20 plus years since the WHI started, we have gone back in the medical community to do studies and to reassess that data. And we found that there were problems with the Women's Health Initiative. The first problem is that women typically go through menopause at age 51, but in this study, the average age of women were 62.7, meaning they were much older women. Many of these women had not been on hormones for a decade or more, and the hormones were suddenly restarted. And so there have been studies since the initial WHI, which analyzed their data and said, you know what, the women who started hormone replacement near the age of 51 actually had positive outcomes. It was the women who were much older, who had a long time, greater than 10 years away from hormone replacement. They are the patients who had more issues with breast cancer, cardiovascular disease, et cetera. The other part of the study that is, we look back 20 years and we realize that we were giving them Premarin and Provera, which Premarin is conjugated horse urine, or pre-mare Premarin. So it was estrogen coming from a horse, which is similar to, but not identical to, the hormone that we have in our system, the estrogens in our system. And instead of giving it topically like we do today, it was given orally. And because that medication was given orally, first, not identical to us, and second, given orally, it passed through our digestive system and our liver and actually increased hormones and compounds that caused more clotting. And so our clotting risk increased because of taking it orally. So one, that drug was not the best drug. The other was the Prem Pro, or the medroxyprogesterone, which is not identical to our progesterone that's in our system. It is a synthetic that's different. And so this drug, when we sussed out the data further, looking at the Women's Health Initiative, we found that these women taking estrogen only did not have breast cancer. It was only the women taking the combination, the estrogen plus the medroxyprogesterone. So this is the drug that was responsible for the increased risk of breast cancer. And what's interesting is the increase was significant. Instead of 4 per 1,000 women getting breast cancer, there were now 5 per 1,000 women. So relatively small number unless you are that one person. So there was a significant increase, although 4 went to 5 out of 1,000. So not that much in terms of a great increase. So the bottom line is, old study done a long time ago, design flaws, wrong drugs used on women at the wrong stage of life. And this fostered a fear of hormone replacement therapy for all of us. And I've spent the last 5 years retraining my brain that, wait a minute, I don't think that is a problem. And let me look at the data. Let me understand the data better, because my brain red flag goes off and says, and so many of my patients say, that's going to cause cancer. When in fact, the answer is that what we're using today isn't the same and we're using it differently. So the problem is we stopped doing a lot of studies. There weren't a lot of studies for about a decade. And then we began to have some studies, but nothing as big as this Women's Health Initiative. So fast forward to recent times, this is the National Menopause Society. They are put out a statement in 2022 looking back at the WHI, and they said, hormone therapy remains the most effective treatment for vasomotor symptoms, which are hot flashes, night sweats, and the genitourinary syndrome, which that means vaginal atrophy and frequent urination, bladder leakage. It remains the most effective treatment for those symptoms of menopause and has been shown to prevent bone loss and bone fracture. So they're supporting it. They also said for women aged younger than 60 who are within 10 years of menopause onset and have no contraindications, the risk benefit ratio is favorable for the treatment of bothersome vasomotor symptoms and for prevention of bone loss. So they came out 20 years later and said, we endorse it. And for me, that's very reassuring as a provider and as a patient. So currently there's new activity coming in terms of research for women. The White House Initiative on Women's Health Research was launched in February of 2022. I'm not much of a star watcher, but I'm pretty sure that's Maria Shriver. Fast forward here, out of that same initiative, Jill Biden announced in February 2024 the Sprint for Women's Health, where $100 million in funding for research and development into women's health has been earmarked. So I think that is phenomenal that we see we need to do more because we are not just men that look a little bit different. We are very physiologically different than men. And then fast forward to just this past May, this is Halle Berry and a group of senators who put forth this Senate bill for advancing menopause care and midlife women's health act. There was a duplicate bill also placed in the House. And while both of these bills remain in what they've been presented, and I think they're in committee, right? So they have to be approved by the Senate, they have to be approved by the House, and then signed into law by president. So not sure if these bills will move this year, but these bills are different than what we've seen in the past. And there's just more momentum, more activity. And interestingly, these bills got bipartisan support. So both Democrats and Republicans were supporting this. So if we're going to understand menopause, perimenopause, we have to understand premenopause. We have to understand how it works before we understand how it falls apart. So here is a slide. If you've hung around Palm at all, you may have seen this slide. And this is just what's happening on multi-levels. So if you look at the very bottom here, you can see the uterine cycle. And this is what we as women, as society see. We see the very first part of the cycle. We see a vaginal bleeding or a menstrual bleeding. And then many of us don't see or think about anything until we come back 28 days later and we have another vaginal bleed. But while we're not paying attention, all kinds of things are happening in our body, and it's just a very amazing symphony. And I'm going to run through it quickly. It is a bit overwhelming, but it's also amazing that it's all happening without our knowing. So our uterine lining is building, and then it sheds again. At the time that our uterine lining is building, we have follicle stimulating hormone. So this light blue is going up, and that is stimulating this growing follicle. As the follicle gets bigger, the surrounding cells will make estradiol. So they cause this follicle stimulating hormone comes from the brain, sends a message down to the ovaries, and the ovaries are creating this follicle, and they're also creating the estrogen, right? The estrogen levels are coming up. As the estrogen levels rise from the ovary, they're sent to the brain, these estrogen levels, and the brain says, oh, I'm going to make luteinizing hormone. And so the brain sends out luteinizing hormone. It goes to the ovary and causes ovulation. We ovulate. And at the time of ovulation, our temperature goes up, which it's not very perceptible. It's not like we have a fever, but it's lower. Anybody who wears an Oura ring and is cycling can see the temperature down and up and down and up. up for 2 weeks, down for 2 weeks based on the menstrual cycle. So that is happening. The other thing that happens is we create from that ovulatory spot, that follicle, we have a corpus luteum, and that corpus luteum produces the progesterone. It goes up in our system. As the progesterone goes up, we are building this uterine lining. If we become pregnant, there's implantation of a fertilized egg in that area, and we have the start of a new life. So very exciting. If it doesn't, there is no fertilization, the progesterone levels will fall, and then we have another menstrual period. So that's how it works. It is very complex. You're not expected to remember it, other than to just be amazed and proud of how wonderful our bodies are and how this happens for years, age 10 to 12 to age, roughly age 51, we're having these menstrual periods. Some of us aren't regular, and some of us are, have pregnancies that interrupt our hormones. We have stressful times that interrupt our hormones, et cetera. But for the most part, our body's in the background doing this all the time. Quite amazing. So perimenopause is a gradual transition from that premenopause where we're doing all this cycling. Things get a little off. And so what we may notice in early perimenopause, like I did back at age 46, was irregular menstrual cycles, mood changes, a little bit of weight gain, some fatigue, sleep is off, brain fog, perhaps a little bit of low libido. And I think the most surprising thing is it's starting 10 years before. And if you think about puberty, right? Puberty, you just don't wake up and have a period. You begin to get little curves. You begin to get a little bit of acne. You get a little hair under your arms. You start to be sassy, perhaps, or you feel jealous, or you have crushes. Then you develop some breast buds. And then within 2 years of breast buds, then we know that you're about to have a menstrual period in that next 2 years. So just like puberty is a ramping on, perimenopause is a ramping off of cycling, and it doesn't happen overnight. There are a lot of warning signs that it's coming. So then there's late perimenopause, and really it's the same symptoms, but they are intensified. And we know that it's late perimenopause if you're having very chaotic periods. So some women have period after period after period, and they seem to be bleeding and stopping for a couple of days and bleeding again, heavy bleeding, cramping, clots. Sometimes there are scanty periods. Sometimes there's minimal or no bleeding, very light periods. And sometimes there are months in between cycles. When you go those long months in between cycles, you really know that you're getting close. We do have a ramping up of vaginal dryness and irritation, and the mood swings can be severe. There can be anxiety, depression, suicidality. It is very serious. Poor sleep due to drenching night sweats, frequent debilitating hot flashes so that you can't get up at work and give a presentation, or you're just embarrassed. And then there's fatigue. And I think we talked to our friends about these things, but boy, I had no idea. I remember telling my friends, I'm going to the dentist again. I have another cavity. They didn't know, I didn't know back then that that was another symptom of my dry mouth, which was related to my low hormones, right? And the other thing I'll mention is that not many people talk about their vaginal dryness. That is just kind of embarrassing, or painful sex, or problems with bladder leakage. A lot of those things are embarrassing. You can talk about your hot flashes at work, but you're not going to talk about the pain that you're having, sometimes even with just walking. So the symptoms of late perimenopause can be really severe, and I think are something that we really want to pay attention to in ourselves, and in the people around us, noticing, hey, maybe you're going through perimenopause. So then there's menopause. And menopause is the point 12 months after the last menstrual period. So you've gone a whole year and you have not had a period. And so no more menstrual bleeds, you've crossed the finish line, everything is great. But the body's never like that. It takes time. So at least you're not having enough hormonal swings to cause these crazy periods, but you can still have fluctuating hormones enough that you're having the hot flashes, the night sweats, the mood issues, the poor sleep, the low libido, the continued vaginal dryness, and many other symptoms. So just because you're not bleeding doesn't mean it's gone. So what do we do about it? Initially, I remember thinking about this as a person, a woman, and then thinking about it as a provider. And I thought, well, that's how we were created. There is a reason why we stop having cycles, and maybe we're just supposed to lose our hormones and that's it. And then I heard a podcast that prompted me to read this book in 2018 called Estrogen Matters by Avram Blooming. And I read it about that time, but I don't know that I really absorbed it at about that time. But the light started to go on for me. And what they said is that we are going through menopause sometimes 30, 40, even 50 years before we die, right? So there are many years that we are going to live without hormones. And without hormones, women suffer significant symptoms and notable health declines. And they also pointed out the flaws of the Women's Health Initiative. So 2 hurdles had been crossed for me. One was maybe it's not good to go without hormones. They brought up a good point. And 2, I don't need to be afraid of hormone replacement because we're not using the stuff we used to use and we're doing it differently. So light bulbs started to go on for me back then. So this year, I really wanted to dive in and decide, how am I going to help my patients go through menopause? How can I guide them through? And so I started to talk to my patients about it. I started to see what other providers are doing. And this is true in St. Louis. And I do a lot of listening to podcasts, national leaders in this space. And they say the same things, that a lot of providers are giving patients oral birth control pills. So when they start to have these crazy periods toward the end of menopause, we are giving women in perimenopause birth control pills. We're giving them contraception so that they have this fake, if you will, period every month, or they can give it continuously so they have no period. They're just kind of shutting the women's hormones down while they're going through these heavy bleeds. And they typically take it away at about age 53, sometimes out to age 55, although they don't want to use it too long because they know about those risks from the Women's Health Initiative when you're taking oral estrogen of blood clotting, hot flashes, blood clotting and breast cancer risk if you're taking combined oral contraceptives similar to the meds earlier. So they use it, but they try not to use it for too long, just to get over the hump of the hard time of perimenopause until after menopause. So what about the birth control? It solves the erratic menstrual bleeding. It probably will not solve the mood issues, probably not the hot flashes. And I have a patient who recently was put on birth control, actually a continuous birth control, no periods. She was miserable, anxious, nervous, fatigue, hot flashes, just felt horrible. So she came off of birth control. We put her on menopausal hormone replacement, and she came back and she had a period. And she said, I don't care. I don't even care about that period. I feel so much better. I'm not going back on birth control, because we were using in her a type of medication that was appropriate. It wasn't a birth control pill. It was menopausal hormone replacement dosing that was appropriate for her. So we will tweak her levels and hopefully knock those bleeds out for her. But we know she's still perimenopausal and she feels so much better. So what's wrong with the birth control pill? Well, one thing is that there's the increased clotting risk from the oral estrogen. There is a slight increased risk of breast cancer with the synthetic progestins that are used in it. And it is known to cause low libido. So I've done a ton of listening in this space, and it is the number one thing when you talk to or you listen to providers, OBGYNs, anyone in the field, they are pulling people off of birth control right away and have immediate changes in libido. So that is one thing. And the other is that there are nutrient deficiencies because of it. So vitamin D, magnesium, and B vitamins. So in general, we try to avoid the birth control at this time. Other options include a hormonal IUD, which is a device, T-shaped device that's implanted in the uterus that typically stops bleeding, but not always. It stops or lightens the bleeding. This is a non-bioidentical progestin. And I've seen some studies that talk about how the progestin is not just locally absorbed in the uterus, but there is systemic absorption of that progestin. And there's actually effects that it has on the breast. So studies showing differences in the breast in women who had the hormonal IUD. Other options are a copper IUD. I don't use either of those, but I do hear there's a lot of unusual bleeding with the copper IUD. Another option for women who are having heavy bleeds is a uterine ablation. So just seeing the OBGYN and they do a procedure where they destroy the uterine lining and there isn't any more bleeding. I think it's very important to address the bleeding in perimenopause because it can be severe. I have a lot of patients who have anemia from their heavy bleeding because they're losing too much blood and they're not eating enough red meat to replace all the iron they've lost. They also may not be anemic, but they may have low ferritin, which is an iron storage marker. And so I have a lot of women who come to me having these heavy periods and they're not anemic, but they feel so much fatigue. And we dig a little bit further than their previous provider and find a low ferritin. So it is very important to get control of this perimenopausal bleeding because you can become anemic or you can have iron deficiency without anemia. Both feel awful. And certainly we want to protect women from that. So the options that I've mentioned above on this screen, they may solve the bleeding, but they don't address the mood changes, hot flashes, or night sweats. So they're a partial solution to the issues. The other option that women have is for perimenopause or menopause is to go to the hormone clinics. And I heard a commercial as I was driving into the office today about, I won't say the name. And what happens there is you get a pellet. I think it's about the size of rice. I've seen them before. It can contain estrogen, progesterone, testosterone. It's inserted under the skin, typically the hip. And patients that I see coming to me who are taking pellets from elsewhere, they feel good. Most of them feel really good. I have one patient in particular that I saw in this past year who came in with hormones and she felt great, or the pellets, and she felt great. When we did our blood work, we found a very high testosterone. It was a testosterone level that her husband would have been proud of if it were his. We call these supraphysiologic. So they give you a lot of energy. They give you a great libido. You can get a lot done. And a lot of women are afraid to come off of it because they're going to miss that edge. The side effect is male pattern hair loss when you have doses this high, and unwanted facial hair, deepening of the voice, acne, and erratic vaginal bleeding. So there are those who believe that these super physiologic levels are great for patients. I feel I always want to try to mimic as best I can how we were created. And women were never created to have an estrogen of 300 or a testosterone of 300 or a testosterone of 900. So try to go back to where we typically would have been when we were healthy. And that's typically testosterone, total testosterone at the highest of 50 to 70. So I keep it a lot lower and I think women feel well. And I will say one other thing about testosterone is that when your ovaries stop making testosterone, which is what they do, it's converted to estrogen. That's how we get our estrogen from there. When our ovaries stop doing that, our adrenals take over. And that's the little glands that sit on top of our kidneys. And our adrenals do a nice job for us. So many women who transition to adrenal testosterone and estrogen maintain a pretty good level of testosterone from our adrenals. We challenge ourselves if we're working out too much, we are working too much, not getting enough sleep, not eating well, drinking, and we have over amount of stress. We can raise our cortisol levels, which are also produced in the adrenals, and then we don't produce as much testosterone. So many times I think that we have to be careful with testosterone because we can make a lot of it on our own. And if we take care of our bodies, sometimes we can do most of that on our own throughout our life, but especially in menopause. So the other option for women in their perimenopausal timeframe is to muddle through. And so if you're like my nanny who took care of my kids, she said, oh, one day I just stopped having periods. minimal symptoms, just stopped having periods. The other option, which is much more common, is that women have a tough time. They tough it out with heavy bleeding, anemia, sleepless nights, anxiety, weight gain, and lots of symptoms. So really, I looked at all of these options and I didn't like any of them. So I thought, well, what does functional medicine do? How am I trained first as a primary care family doctor and then as a functional doc? And even from my first days of med school, literally first day, the answer to every disease, every different type of disease was how are they living? What's their diet, exercise, sleep, stress, and even then, how much toxin were they exposed to? And so that's something that we really focus on in functional medicine because we know if we can optimize those things, that people feel a lot better. That's always part of the equation. If we are not sleeping, working too hard, very stressed, running through the drive-through, not taking time for exercise, we aren't going to do as well in perimenopause. But if we're doing all those other things, we will feel much better. So first of all, work on the lifestyle. Second of all, I look at patients who come in and have issues, and I want to make sure they don't have heart disease, that they don't have low thyroid, that they're not anemic, they don't have a low ferritin, that they don't have an autoimmune disease. When I've ruled out all of those things, then I'm going to treat the root cause with supplements and medication. So we're just looking for the root cause. And so just to dial in on the holistic management, this is very important. And I'm really proud of what I'm hearing in the menopause space. A lot of providers, whether they're functional, whether they're OBGYN, are talking about all the holistic things that you need the sleep, you need the careful diet. And I tell all my patients, if you've ever had a visit with me, you need to eat 3 plates a day. I don't need you eating all day long. Pick a 12-hour window or pick an 8-hour window and have 3 plates spread throughout that time. Fill half of the plate with veggies. Eat them first. The next part of your plate, protein, 30 grams of protein, nice quality protein, and then get a little bit of fat. And then throughout the day, after you've eaten all that, you could add a fruit or a grain, 0 to 2 fruits, 0 to 2 grains per day. So it's really, really important during this time, this perimenopause, our system is changing and we can't get away with maybe what we got away with before. So what we eat really matters. We want to feed our body intentionally. Exercise is really important. We want to get 150 minutes of cardio, so just breathing hard. And we do want to do that whole body strength twice weekly. And so many women who are in the perimenopausal range are just walking or playing pickleball, and they're getting the cardio, but not doing the strength training. And I will say that I have some strength training programs that I have learned here at Palm with our personal trainers that I have memorized, and I do just body weights. So it's push-ups, planks, squats, etc. I've also used P-Valve, which is an online subscription that you can use to help you strengthen the muscles and to strengthen them purposefully so that you can do all the acts of living, sitting, standing, bending, lifting, carrying, all the things you'll need to do for the rest of your life. So lots of options, but I encourage everybody to find a place for strength training twice a week. Don't forget stress management. We need our adrenals to be in good function. And if we are burning the candle at both ends, our adrenals are not going to work well. So take time out each day for prayer, meditation, yoga, nature, whatever it is that keeps you calm. And final thing is toxin avoidance. We are exposed when we get up in the morning and we take a shower. What are we putting on ourselves? When we get out of our bed, what was on the sheets that we slept in? What products are we using? So the EWG app or the Yucca app can help us buy products that we put on us or wash our clothes in to help us stay safe. We can also limit our alcohol consumption, and alcohol is really hard on the body. It's a lot of work to do. So if we are tired, exhausted, and we just need a glass of wine to wind down, I would say you just gave your body another job to do. And your body was going to try to manage your hormones, but now it's got to work on the alcohol because alcohol gets first priority. It has to be dealt with. We cannot store it in the body. We've got to get rid of it. So anything else, the carbs, the fats, that all can be stored, but alcohol cannot. It's got to go. So not that you should never have alcohol, but I would think carefully about it because that causes toxin development. We have to work harder at our liver to detoxify that, and it makes it harder to manage our hormones. And I think in this space, I've heard a lot of individuals talk about how they feel the same way. It's not you should never, but it's you should really be careful with consumption. And if you're having alcohol on a daily basis, cut back because it's putting a strain on your body. All right, I want to take a minute to talk about all my patients who come in and talk about weight around the middle. I think that is really, really important. It's very frustrating. And I think women are really frustrated when they see the scale go up, right? I think they're very, very happy when they see the scale go down. And I usually am too. And I say, wow, that's great. And then I say, wait a minute, what did you lose? And so that's why at Palm, we frequently check our patients with a body composition analysis where we're looking at their fat mass and their muscle mass and their belly fat to see what's happening. We know there's very good data with menopause that we have more insulin resistance. We store 3 times more belly fat easily without changing our exercise, without changing our diet, and we are prone to muscle loss because we don't have the hormones in there causing us to make muscles. So I think it's really important to really love your body and figure out what's happening with your body and then give your body what it needs. All right, so the obvious symptoms, we talked about all of these: hot flashes, night sweats, moodiness, poor sleep, libido, menstrual problems. Here's the not so obvious. And I think it's really, really important. And I'm going to stall on this slide, so you might get sick of looking at it, but it's very important to know that we have estrogen receptors all over our body. So there's a change when we have less estrogen. There's an area in our hypothalamus that controls our temperature. If we don't have estrogen in those receptors, we can't control our temperature as well. That's one example. Example number 2 is vaginal dryness and atrophy. Kind of the skin gets thin and irritable. That's because we don't have estrogen going to that tissue and the tissue is not maintained. And so you can have pain and discomfort, urinary tract infections, vaginal infections, all sorts of things can happen because that tissue is not maintained. But the same is true for all over our body. So our joints, there are estrogen receptors in our joints, and we have more joint pain and stiffness in menopause. So frozen shoulder has been directly linked to menopause, which that was new to me as a month ago. I had really not thought of that, but the data is impressive. Gastrointestinal upset is super common. I see many of my women coming in with gas, pain, bloating, constipation, diarrhea, and that plays havoc on the hormones. As the hormones fall, our gut diversity changes and we can get more gut issues. And when our gut isn't working right, we don't detoxify and take out the trash, and estrogen is in our stool, we don't take it out regularly, or we take it out too regularly, and we have this imbalance. So there is, gut upset. Brain fog is really related to perimenopause. I remember in the past 5 years having word finding issues and thinking, I am just like my freshman high school computer teacher. I remember finishing her sentences and I was so embarrassed for her and kind of embarrassed for myself. And I thought, oh, this is awful, until I realized that our brain totally rewires itself. If we don't have all this chit chat between the ovaries and the brain, we're going to have different architecture. We're going to get rid of receptors that aren't being used. And so our brain is rewiring. And so that creates a temporary, in many women, change in how our brains work. And if you look at Dr. Lisa McConey through Weill Cornell Medical School, she put out a book called The Menopause Brain and has studies looking at functional MRIs of where the estrogen receptors are premenopause, perimenopause, and postmenopause, and they are vastly different. So you're not making up the brain fog, you're not crazy. Burning mouth is associated, fatigue, dry eye, again, estrogen receptors in the eyes, dizziness, urinary tract problems. hormonal headaches and migraines, palpitations of the heart, right? The vessels and the lining of the vessels are affected. The muscles of the heart are affected. Our cholesterol goes up. Our triglyceride goes up. No diet change, no exercise change, just in with a drop in hormones. We know for sure, and there's FDA approval to treat osteoporosis with estrogen because it is pro bone. It helps us grow bone. We're constantly remodeling our bone, breaking it down, building it up. Estrogen causes us to do more building up. Without estrogen, we just continue to break down our bone. We get osteopenia, osteoporosis, and we have fractures. And so while you may have sailed through your menopause at 50, out at 60, 61, 62, you might break your ankle walking off the curb, which happened to one of my patients recently. She was so frustrated, so very frustrated. She had just come to me and hadn't had bone density testing, hadn't had hormone replacement. Really frustrating and totally preventable. That's, life altering for her temporarily. It's not a hip fracture, but it could have been. And so we want to prevent that. Muscle loss, we talked about thinning hair or unwanted hair where it should not be, the belly fat, weight gain, the skin changes, we all know about that. And then tinnitus is actually related because the lining of our inner ear is affected. So lots and lots of things. It is so much more than hot flashes and night sweats. And this is what it looks like when you look at estrogen, progesterone, testosterone, melatonin. This is a European spelling. But when you look at it over age, so 25, everything's nice and high. Out at 75, it's nice and low. And right around 50, it takes a steep decline. And as you look at that, that's not a very gentle, first of all, it's a steep slope, but it doesn't just go straight down. It goes up and down and up and down. And as we have those hormonal variations, that's when we feel the worst. We feel good and then we feel bad. And our body's constantly trying to keep up and try to plan, but it can't because everything is erratic. The very minimal change as we go throughout our cycles. And then these great vacillations here causes a lot of discomfort for many women. So what do I recommend for patients? Of course, all the lifestyle stuff. I do recommend supplementation, and I start out always with a multivitamin, vitamin D, and the levels vary. We want the blood level to get up. The dosing, I should say, varies because we want the blood level up to 40 to 60. I love to add monopure fish oil by Zymogen because it is very anti-inflammatory. It's pro omega-3. And I check many of my patients for their omega-6 fatty acid versus their omega-3. And many of us are just deficient because we live in the middle of a country and not on a coast. So I love those three. I think they're very important and foundational. If you have skin issues or bone issues, I love to add collagen. If you're suffering from insulin-resistant metabolic syndrome, I like to add the pendulum probiotic because it supports the gut, and a supported gut processes better and helps decrease our insulin and improves our blood sugars, which helps with our weight maintenance. And as an aside, this probiotic also calms the gut as well. So it's a dual factor. And women are many times having the metabolic issues and wanting to lose weight loss and having the gut issues. So I love that supplement. I like this brain fog support by Best 365. This is a methylene blue product. Currently taking it, and I can tell you my word finding, maybe you didn't notice it today, but my word finding is much better. I'm much more quick, much more sharp. That has been very beneficial as that methylene blue brings oxygen to my cells, supplying my mitochondria with oxygen and then taking away the byproducts. Just a lovely product. I do have a lot of women who take the Regenemax Plus. This is for hair, skin, nails, and bones. It has biotin, silicon. We've got samples at Palm. You can check it out. But bone supporting moieties in it that are just phenomenal. I love OptiMag Neuro as well. And this is lovely for calming and for helping with sleep. And it's a powder that you can take as a drink at night. And I really like OptiMag Neuro when I have had a hard day and I'm exhausted and maybe I'm a little edgy. I will have ice water with a lemon and some OptiMag Neuro before bed. And it's super calming. And I know that I'm not giving my body another job to do. I'm not having a glass of wine that might disrupt my sleep and might cause me to have detox issues. And if I have a glass of wine, my Oura ring will tell me. It'll say, I'll look at it and say, oh yeah, my heart rate stayed up and all kinds of things. If I have the OptiMag Neuro, I sleep so much better. So something to think about instead of having the cocktail. Creatinine, I think, is lovely because it's, first of all, we thought for a while that it was not good and was harming our kidneys, but lots of great data about it currently. Creatinine is pro muscle growth. And I think we all want to be at the gym working out or doing our workout wherever we are. And we all want to be eating our protein at every meal, but having a boost of creatinine can be fantastic, or pardon me, creatine. My other favorite thing to add, and these are just things I have at home, and I brought this one on specifically, is it's Pure Paleo by Designs for Health, and it's a protein powder. And I get the unflavored one, and if it's just a very large scoop, is 30 grams. And so you can put that in anything. Today I put it in my homemade butternut squash soup, and that gave me all of my veggies and 30 grams of protein. Many times I'll put it in my veggie and fruit smoothie. So end up having about a scoop a day. I think it's an easy way to get protein. So those are some suggestions. Also at Palm, we have cryotherapy, which is lovely if you're having a hot flash. It's great. It's also builds up your dopamine and it helps you burn calories. So I love that. I love acupuncture because it can be beneficial with hot flashes, sleep, night sweats, etc. Massage is fantastic. And then, of course, all of the classes, the Pilates, strength training, yoga, I think those are great. And it's neat to be within a class of other people kind of pushing each other. And then there's personal training, which I've experienced here at Palm. And I really like someone to watch you, take a look at what you're doing. You can tell them what you need, what you're trying to achieve, and they can help you. So menopausal hormone therapy is an add-on. When you've done all the other things, we believe that it's safe and effective for perimenopausal and menopausal women, and that we do not have to wait. Many OBGYN providers will say, you know what, you can't do it until you're menopausal. You got to wait until you're menopausal. And what happens is you've been through this up and down, up and down, up and down. You're slowly coming down on hormones and you're feeling miserable. And it's years of that until many women are offered hormone replacement. And we like to work with our women before menopause to help alleviate some of these symptoms. And then we customize it to each woman to meet any particular need, right, to wherever she is in that transition. So what we use is I prefer, and most of us at the practice are using a twice weekly estrogen patch. It has a very steady, reliable delivery system. It is FDA approved, and bioidentical is kind of a wonky term. What we're saying is it's identical. Your body cannot tell it from the, if you ask your body, is this from your ovary or is this from your patch? It doesn't know. It's the same estrogen. So it's readily available at any pharmacy. It's covered by insurance, and it is much safer to take it as a patch on the lower abdomen, replacing it usually on Thursday and Sunday, because it does not go through the digestive system, not through the liver, and we don't have the increased clotting risk. It is currently FDA approved if you have hot flashes, if you have hot osteoporosis, and if you have genitourinary symptoms of menopause. So that is estrogen. I will add that we use vaginal estrogen in some women who are taking the hormone patch, but everything else feels great. Night sweats, hot flashes are gone. Mood is great, but they're still having vaginal dryness. We add additional twice weekly vaginal estrogen tablet, and that really can solve the urinary tract problems, also the pain and discomfort in the vaginal area. For any woman who has a uterus, we have to use progesterone, and we are not using medroxyprogesterone. We're using micronized progesterone. We're also using it for some women who don't have a uterus for two reasons. One, in our lifetime, we've always had a balance of estrogen and progesterone in our bodies. And we have progesterone receptors all over the body as well. So just because we don't have a uterus, we believe that many women benefit from progesterone alongside of their estrogen, whether or not they have a uterus. So we're using, it's called Prometrium. It is an oral micronized progesterone. It's FDA approved. It is identical to what your body has. It's available at any pharmacy covered by insurance, and it is safer than the medroxyprogesterone. And that's what was in the old study, the Women's Health Initiative, and in birth control pills. That was linked to that higher risk of breast cancer. Currently, there are several French studies, and again, not a lot of studies are out there because everyone's still freaked out about the WHI. But there are studies, some French studies, I believe a Danish study as well, talking about the benefits of micronized progesterone and how it protects against breast cancer. We know for certain that it protects against uterine cancer. And we know that the body converts it to allopregnanolone as you take it in orally and causes it to land on your GABA receptors and promote sleep. So we can never guarantee 100% that it will not in some way increase your risk of breast cancer. We believe that risk is so very small. And when you look at all of the other benefits of hormone replacement, it is an individual decision, but we believe that the risks are slim and the benefits far outweigh. So testosterone, it is the most abundant hormone in a woman's body. So men have more of it, but we have more testosterone than we have estrogen, than we have progesterone. It improves our energy. It can improve our libido. It promotes muscle tone, muscle mass. It's associated with better bone health. However, it is not approved for women. The FDA does not approve it at all. And there are no FDA approved medications. So I can't go into my system and say, I need the women's testosterone. What we have is a bottle of testosterone that's a high concentration, 200 milligrams per milliliter. And that's pretty high. And we need, as women, a tenth of what men have in their system. So we currently compound our testosterone for women because many women, even though they're doing all of the things, still have a bit of a low testosterone. And so we use the cream, which they can put on their inner thigh, inner arm, to help with their testosterone level. What we found with that is that there's some variable absorption from woman to woman, and from one time that you purchase the compounded to the next time. And so we wanted to do something a little bit more precise with it. So we're working with our compounding pharmacy right now to create not a 200 milligram per milliliter, but a 40 milligram per milliliter, which will be designed for women. And we can give it at 10th of the dose that men would have. And that will help us just boost that testosterone into the physiologic level, not super physiologic. We really don't want any side effects for our women, but we do want them to have the benefits. So in summary, menopause and perimenopause are associated with lots of long-lasting and significant health effects and issues with well-being. Many primary care and gynecologic providers just aren't equipped. They don't have time, they don't have the energy or the interest to dig into all of this. And so you want to find the right person to help you with it. We know that lifestyle habits are big. So you can just take a hormone and do whatever you want, but the hormone's going to work so much better in a healthy host, in someone who's sleeping, eating, exercising, reducing stress, and limiting toxins. And we know that it can be safe and effective for the management of premenopausal and menopausal symptoms. So I got my info first for this presentation over the last year. I went to the Institute for Functional Medicine where I did my training in 2015, and I repeated their latest update on the hormone module. And I got a lot of information, but I wanted more. So I kept digging. From there, I went to an A4M conference, and I learned about, this is the American Academy of Anti-Aging Medicine. They have a whole hormone seminar that I went to, learned a lot, but again, still wanted to know more. And then I did a bunch of podcasting. I'm like, who's out here in this sphere? Who's doing it? So Kara Fitzgerald is an Institute for Functional Medicine provider. She's Northeast. Can't remember which, maybe Oregon. She does a fantastic job, has a podcast, has a great practice, and does a lot with women and women's care. And she's gotten very deep into the research with that, and she is working with Mira. And Mira is very interesting. It's a device that you can purchase and you can check your hormones every day if you want. You can see where your estrogen, progesterone, and estrogen, progesterone, and LHFSH, where those guys are every day. So you can tell if you're ovulating, if you're not ovulating, and where your levels are. So super, super interesting. We did bring that on board. Next, I went to Ben Bickman, and he is amazing. He talks about metabolism and explained and really highlighted for me the insulin resistance that happens and why we get belly fat when we are perimenopausal. And then Peter Attia, who is a phenomenal functional medicine doc, who always does a deep dive. He asks all the questions. And so I listened to every podcast he did on hormones, of all of his podcasts, and just reviewed his research and learned a great deal from the excellent people that he brings on from the best institutions. So really took a deep dive with him. I have not read, but it is on my list, and I've heard her talk quite a bit. The Menopause Brain by Lisa Moscani. She's got that great data about how our brains change. That was very illuminating for me. Actually, a patient alerted me of this, and I didn't know how significant the brain changes were. And her talk really made me feel like I wasn't crazy. So maybe I am, but put me in context with all of the other women. And I think the most important book I read, and I would recommend it to everyone, is The New Menopause by Mary Claire Haver. Just a phenomenal book talking about the history of hormone replacement and all of the changes. She's an OBGYN, all of the changes that she has seen in her own practice, in her own self, and looking at all of the data that we have regarding perimenopause and menopause and safe hormone replacement therapy. So thank you so much. I really appreciate everyone coming and taking their time to listen to this webinar.